All right, welcome to the Seeing Eye to Eye podcast, episode 3.
Episode 3.
With
Max Medert.
And Shannon Wong.
Welcome back.
Good morning, Max.
Yeah, good morning. This is our first morning show. Well, we tried in the past, but we had to delay. That's a long story.
That's right.
Anyway, we're nice and alert and ready to talk about important things that they do not teach you in medical school. Now, I know you have a prepared statement you'd like to share with the group here.
Not really, nothing prepared, but yeah, this is what they don't teach you in medical school or residency, but you need to know.
Mm-hmm.
So first thing we want to talk about is when you go to medical school, do you really know the business of medicine? Do you understand how you're being paid as a doctor? Do you just do the doctor thing and then magically get paid?
Mm-hmm.
And do you get paid by the patient? Do you get paid by insurance? Do you have any idea what you get paid by insurance? Mm-hmm. Is insurance the patient's friend? Is insurance the friend of the doctor? Because wasn't Obamacare a law saying we all had to have medical insurance, right?
Or you'd be taxed.
Right. So if we had to connect the dots, then I would assume that insurance is our friend.
If the government thinks you must have it, it must be your friend.
It must be good. And if the government is behind it, it must be good. All right. So what I did, and I'm going to throw this up, well, I have it up here on the screen. Some of the most commonly performed procedures in the country, according to Johns Hopkins, we have these procedures, which you can see. We don't have to read them out. But I did a little digging because we're ophthalmologists. We know ophthalmology. Mm-hmm. But I wanted to kind of sample the other specialties. And this source, centralsurge.org, shows for some commonly performed surgical procedures. These procedures look like they're being done by general surgeons. The trends in Medicare reimbursement over the past 12 years, and we see a slight downward trend. And then if we look at this other orthopedic publication, these are common orthopedic procedures, and the chart is changes to inflation-adjusted Medicare reimbursement for orthopedic sports medicine procedures from 2000 to 2020.
This is total reimbursement, correct? Not just professional? Do you know?
I think this is, if I had to assume, and I didn't dig, but this summary of differences among orthopedic sports medicine procedures, these are probably procedure payments to the physician year by year over time.
We should explain that, right? That when you bill a procedure to an insurance company or to the patient, there's two parts basically, right? The professional fee, which goes to the doctor that did the procedure, and then a facility fee, basically pays the hospital, the surgical center, wherever you had your care delivered. So those together would be the total cost of care.
Right. So so for example, let's say you go get a knee replacement. The John Doe is the patient. Dr. Jones does the knee surgery, and Dr. Jones bills the doctor fee, also known as the professional fee, and then the hospital or surgical center where the knee replacement was performed also bills the patient, and that covers the cost of the building, the equipment, the supplies, the nursing staff, and all the things that go into the infrastructure to support the doctor to do the knee surgery. So you're right. And in fact, there's a third payment. There's usually an anesthesia fee.
Oh.
So usually most procedures require anesthesia, and so a lot of specialties involve an anesthesiologist, and they charge another fee.
A separate professional and a separate facility within that? Do you know?
I'm
just curious.
I'm not sure.
Yeah, we can look into that.
Yeah.
Okay.
But you can see the trend is a downward trend over time for, let's assume these are surgical fees, the procedure fees billed by the surgeon. And so then I looked up, well, this is a publication from the American Medical Association. Medicare physician payment is not keeping up with inflation. Why are physician services taking a back seat? And these are the Medicare updates compared to inflation from 2001 to 2022. And basically, you can see that the change in physician payments for the facilities like hospitals and outpatient surgical centers, and it also includes like retirement homes, which are also known as skilled nursing facilities. It goes up, but the physician reimbursement, though over time it may go up, it's not keeping up with the inflation rate.
And there's a gray line there that says practice cost, right? That's an important one.
Yes, so
That's rising.
That's right. So let's say you have Jimmy or Janie who works in the doctor's office, they're being compensated at a certain rate. In 2001, they were paid X dollars, and they get probably a cost of living or merit raise of, let's say, 2 to 10% per year. Well, ideally, the income to the practice should cover or account for the increase in compensation that the support staff will require to want to continue to work with the doctor, but it's not the case. And let's go another step forward here. We do cataract surgery. This is the reimbursement for cataract surgery over the past 30 years. And when I started out in practice, it was about $780 here in 1997. And in 2024, that same payment for cataract surgery has gone down significantly.
So it's absolutely lower, and it's not adjusted for inflation.
Right. So this is a chart that I found. Let's say I was paid based on this chart. In 2000, I was paid $720 for cataract surgery. What should I be paid just to keep up with inflation? $720 in the year 2000. I would need to be paid $1,286 today just to keep up with inflation. But in reality, we're compensated half that. So
it's looking really good, right? I mean,
yeah. So what are your thoughts about this, Max? You're new in your career, and what are your thoughts?
I remember distinctly when I told my mom I wanted to be a doctor, she was really worried about this. She was familiar with physician reimbursement problems because she worked in a dermatology office, and I'm sure they were discussing this at the time, and she could kind of see the writing on the wall a little bit, and she was a little... It's interesting. Usually parents encourage you to go to medical school, I think, but she was a little discouraging, sort of a, hey, buddy, be careful. It's not what it used to be. And I was sort of like what I think a lot of people are when they go to med school, which is sort of like, well, whatever. I'm not going there for this. I didn't study these numbers before I went into medicine. I went into medicine because I want to help people, or I want to exercise science in a way that directly has a direct output, or I can see how I can apply my, intellect and get an instant, response from that in a tactile, real way. So anyway, my feelings about it are, I guess I did get a warning, but I didn't really take that advice too seriously. And I bet a lot of folks do not, or have not taken that seriously, because they kind of are used to going to big universities and big, powerful health centers and just seeing that as normal or good. And like you said, just kind of trusting that the money will make it there on its own. You don't need to think about it or worry about it. It'll figure itself out. But the reality is that's not the case.
Did you have any courses in medical school or residency where they talk to you about the business, how doctors are paid?
I have a vague recollection that we had a couple private practice people maybe come in and talk about it, but it was the lowest. My feeling was this was the lowest yield of my time because of my context, because I wasn't worried about that. And the people that they brought in, to my memory, didn't do a service to what private practice is really like, meaning they were kind of flashy and just so business talk, I walk this walk that I couldn't understand it because I was a science person and it didn't come down to my level, if that makes sense. It felt like an alien world and something, again, I didn't think I had to worry about because I never thought I'd work in private practice ever.
What did you think you were going to do? How you were going to become an ophthalmologist, and then what were you going to do?
Work at a university and let the university worry about the payment and all that.
And so you were just you would be content working out a compensation package with the university, and then just going along with that.
Yeah, and I think that's what a lot of people are thinking or expecting, and then end up doing now because of these trends. And we can talk more about that later. But
Right.
yeah, I was sort of content with that because my main mission, other than to apply the science and all that, was to educate and be a teacher. And so I was like, well, okay, that's very logical. If I work at a big hospital, I will teach. I will have residents. I'll have medical students. And that's really my main goal. The money is not the main goal here. And I saw advantages too to the hospital system where I could kind of get whatever I needed or wanted in some ways. Now there's limitations to that, but there's certain things that hospitals can do that private practices generally cannot do because they have a lot of leverage. And we can see this from the chart that they have a lot of leverage because they're being compensated more fairly, honestly. Hospitals, universities, because universities run hospitals, and I think they're getting the same deals that you were showing up there.
Yeah, so I think, do you realize that hospital operating rooms, or HOPD, hospital outpatient, I guess it stands for procedure departments, are compensated at a different scale? They pay, insurance companies pay hospital outpatient departments more for the same procedure than they pay surgical centers. Are you aware of that?
Yes. Yeah, so at ambulatory surgical centers, they don't like cataract surgery because of the reasons we just showed, that it's very difficult to recoup your costs. But I wasn't thinking about ambulatory surgical centers. I always thought I would operate in a hospital. That was the normal.
And was the hospital outpatient? Did you work at a hospital in your academic position?
Yeah.
Was it efficient?
No.
Like, what was the turnover between cases?
An hour.
Oh, wow. Our turnover here is 6 minutes.
Right.
Preferably less, 5.
Right.
And if we run 2 operating rooms, it's 3.
Right. So, yeah, you're kind of wondering where all that money goes in some ways, but yeah, we can dig into it. I think hospitals eat a lot of pain for the city that you live in.
They do.
They absorb a lot of debt.
Yes.
And take a lot of patients who cannot afford care or have a complexity of care so high that no other place could really justifiably or safely take care of them.
Right.
And so I get that part of it, and so I respect that. I respect that hospitals do big things for their communities.
My understanding is hospitals, they do charity care. They have to be open at all hours, take emergency care. And so that's my understanding of what justifies their higher compensation scale. Ambulatory surgical centers like we operate out of, we don't really take many emergencies other than our own. We'll see our own patients who are established in our practice, but let's say Susan flies in from Kentucky and has an eye injury. They don't usually come to our surgical center for their emergency care. They go to the hospital outpatient department.
Because we may be closed,
Right.
or
That's right.
it's inappropriate because they have too many other injuries. I just think about the things they had at Emory, these neurosurgical suites with lead that's suspended from the ceiling so they feel no weight on them so they can be ultra precise with their movements. I mean, that's an incredible investment to do extremely high level care that costs a lot of money. So I get why there's an increase in costs over time. Also, we have an aging population. You're saying 20 years ago, people that were 50 20 years ago are 70 now. And that's a big difference in a person, on the average person. A lot of people start having health problems around their 70s, late 60s. And so things are kicking in. We have more older people. It makes sense. But what doesn't make sense to me is that the physician reimbursement hasn't matched that.
Where do you see this going? Let's say you're paid for your cataract surgery $528. Let's say, maybe that's not the best analogy because we can talk about how we reconcile that. But let's say you're a orthopedic surgeon or a general surgeon who's doing a medically necessary procedure, and you were paid $750 for that procedure in the year 2000, and now you're being paid $500 in the year 2023. And let's say fast forward in 10 years, you're paid $400. How do you think that works out?
Well, we know what happens based on what's happening right now, I guess, which is that you sell. You cannot sustain your business because as a private practice person, so you either group up with other doctors, create a medical group, I think is what it's called. Try to hang in there as best you can. Maybe get an ambulatory surgical center so that you can benefit from the overtime increases in reimbursement for centers that provide care like hospitals or ASCs, or you sell to private equity, which, I'm not an expert at PE, but basically it's a company, right, with deep pockets that looks to transform your practice into a money-making venture. That's what they do. They're pretty open about that. I don't think that's a secret. And then, or sell to a hospital or a university, or go out of business. I guess those are your options.
Yeah. So do you think the doctors of the future, do you think doctors understand, number one, how they're being compensated or how they will be compensated, and that the trend is a downward trend for them?
I don't think they realize it until they graduate, which is the point, I guess, of this podcast.
Too late.
Yeah. But they don't tell you in med school. I don't think they tell you that. And even in academics, you definitely feel it. Like you feel the money because it's talked about all the time. We can't buy this, we can't buy that. We have to pay the dean's tax, which is basically every year, whatever money your department makes, you have to give the dean a certain cut of that so that they can fund ventures for the hospital, for education, all of this. So you're just getting cut at all these different angles, even within that setting. So you're always thinking about the money in a way. It's just not as direct when you're in the academic setting.
So when I was very young, I saw my dad practicing medicine, and the compensation for, let's say, cataract surgery was probably $2,000 to $2,500 per cataract.
Wow.
Granted, cataract surgery was slower, less efficient, longer recovery.
Greater
But
risk.
$2,500 in 1985 per case, compared to $528 in 2023, which is like 40 years later. It's quite a change.
I do feel like, of course, you said it, basically the surgery has become safer, which is great, and more efficient, which is also great. But at the end of the day, the patients are still patients. They're still human. So they have all the same risks, baseline factors, weak zonules, which are the strings that hold the lens, dense cataracts that increase the risk of corneal issues, or the bag that holds the lens in place being injured. Patients are still the patients, And so what I'm trying to say is medicine is still hard. Even though things have advanced, there's still a high level of difficulty and responsibility that's placed on the doctor. And the way it's being recognized at least from a financial standpoint, by the insurers, especially Medicare, doesn't make sense to me.
So who made these rules? Well, my thought is, and I'm not an expert at this, is that we have politicians in Washington, D.C., working with Medicare, Medicaid, also known as CMS, Centers for Medicare and Medicaid Services, to formulate policy. And Medicare sets a budget for what they're willing to pay doctors for their services. And then private insurances look at what Medicare fees are, and then they adjust the private insurance payments to doctors and hospitals and surgical centers based on what Medicare does.
You let them lead.
Yeah, so if Medicare is setting the tone, then the other insurers follow. But the trend is definitely down. So if I am a highly ambitious student and I'm seeing these students in college who work really hard, they're staying focused, playing by the rules, they're getting into very good medical schools and accruing debt and jumping through all the hoops to go through medical school, and then there's the opportunity cost of spending additional 3 to 10 years of additional training after that to learn your specialty, and then we're taking very talented, almost like top 1% academic performers, and it's something to think about, because when you're out in the real world and you've paid your dues, jumped through all the hurdles, delayed gratification until you're like 30 plus years old, while you saw your counterparts, your friends from high school, maybe not having to go through all that process, and they're doing, I guess, financially very well, better than you. Does that matter to doctors? I don't know.
I think it will start to matter. I think this may start to have an effect because people are so focused right now on the economy and inflation and all these things. So it's very much in the front of our minds. Now, I guess when I was finishing high school, we had the financial crisis, and that kind of put things into stark relief. But I knew I was picking a technical degree, not an arts degree. And so that was sort of my pivot. But maybe there's going to be a bigger pivot towards, basically not going into medicine. And so we'll have fewer and fewer people going in, presumably a lot of our high-level candidates, and we'll have a brain drain. And we'll have to take people who aren't as qualified.
Have you seen any sign of that?
No.
I haven't either. And I interview these people.
Sure.
And I'm reviewing their resumes. I'm going, oh my God, these guys are so much more qualified than I ever was. And I thought I was very qualified in my time, but I'm going, wow, these are really talented folks. I don't think they know what they're getting into in the business world. So then they're going to come out in the business world, in the real world, and I guess you have a couple options. You can work in academics. You can work for a hospital. You can work for a practice that's owned by a private equity group. You can join an established private practice. You could start your own practice. What do most of your friends do?
Let me think. For my year, three are in PE owned, 3 of us are in private practices owned by doctors, and then 1 is solo. He's starting his own practice.
Mm-hmm.
So that took me a while, but I got there.
No, that's good.
So kind of a spread, and
Yeah.
more doctors focused, either solo or groups than I would have guessed. I would have anticipated more academics, and then maybe even a little more PE.
So I should share kind of how do we get around in our own world, in our own private practice. We're a private practice, and we're not owned by private equity. We're not owned by a hospital. We're owned by the doctors in the practice. How do we get around this decreasing reimbursement trend? First of all, the doctors who run the practice have to be entrepreneurial and driven and talented. So they have to be able to deliver really high level care consistently so their patients are happy, because that's the foundation of everything. Like when we're doing our work, we need to be on point, accurate, just on the mark pretty much every time. And if we have unhappy patients, it should not be because of the fact that we were not on our game or that we missed something. You're going to have unhappy patients even if you're batting 1,000, just because people are
Human
people.
nature.
Yeah. And then the entrepreneurial side says that if you're going to practice, at least in our field, ophthalmology, we took the time and effort and made an investment to build a surgical center so that we own. And so now when we do our surgical procedures, our most common procedures, cataract surgery, if the patient's going to have cataract surgery in a operating room somewhere, they're going to be charged that operating room or facility fee, and they're going to be charged a surgical fee. Well, we decided that we're going to be the facility. So we're the facility and the doctor, so we're able to collect both of those charges. And then a third component is we have ridden the wave of elective medicine, where if we offer a service that insurance doesn't cover, therefore insurance doesn't control the cost structure or the payment structure. So we do lens replacement, premium cataract surgery, LASIK surgery. These are elective procedures. We set the fee, we collect from the patient, but we have to, that's retail medicine. That's consumer-driven healthcare, and we have to bring value to the patient in order to merit that. Because just like anything that is consumer-driven, the consumer will shop around and try to find the match that best suits them. It's like if you're trying to buy a pair of shoes or if you're looking for a women's handbag or an article of clothing, there's a market there for everything. There's a market for value. There's a market for luxury. There's a market for quality, or a combination of all three. So we've kind of chosen that pathway, and that is a viable pathway for our narrow niche of ophthalmology, but it's not a viable pathway for most of medicine.
Yeah, you don't get a elective appendectomy or like a cosmetic appendectomy,
Right.
as far as I know.
Or a cosmetic, let's say, knee replacement.
Sure, my knees don't look good.
Yeah.
Take it out.
So I don't know what the future holds for those specialties that cannot follow an elective pattern. So like, for example, I have a family doctor. Well, my family doctor, who I used to see, retired, and he took my insurance. So I transferred to another family doctor who I was willing to pay out of pocket for. Okay. And that's no problem. I said, I'll pay you, doctor, for every visit I see you, because quite frankly, when I was trying to call the family physicians, they had farmed it out to nurse practitioners. And the level of customer service was commensurate with the declining reimbursement scale for doctors, meaning there was no customer service even for scheduling a new patient, such as myself. So I said, I'll pay this guy cash and see them. But I guess it's so hard for like the family doctors. They chose to consolidate to a concierge system where they now want, I think it's over $2,000 a year per person to be the concierge family medicine doctor, where they'll take care of you. But unless you really consume that much in healthcare per year, which I don't think I do, it's probably not necessary. So this is the world of primary care. They're getting smart, and they're thinking it's a business, and we need to. I don't want to just be a slave all my life to the downward slope.
Well, what's interesting though, just to counter that a little bit, is the argument that CMS seems to have made is that a lot of the adjustments in reimbursement, especially to surgical subspecialties, has been to the benefit of family medicine. So that was their stated goal, was to increase reimbursement for primary care so that more medical students decide to go into primary care. But that hasn't happened. This has been going on for a long time. The number of primary care doctors really hasn't changed that much. And in fact, what they do instead is they just see more patients. And so you get shorter visits with your primary care doctor, and the experience goes down, and it's a cycle. And then they're cutting the other reimbursements for the subspecialties, so they get less and less interested in being on Medicare. And then we can talk about what that could mean.
It leads to like physician burnout, a poor patient experience. So, for example, I can even speak for my own kids who, when they go to the doctor, they actually say that healthcare kind of sucks because their experience with the doctors is not good. It's somewhat of an assembly line process, and it's inefficient, and I think a majority of their interaction is with the office staff who don't seem to care, and which leads to the experience being very poor.
Yeah.
But then you have to ask yourself, why wouldn't the office staff be able to deliver better customer service? It's a vicious cycle. So the doctors have to slave away like a rat on a wheel. They're being paid less. They may not be able to as readily afford to recruit, hire, retain, train,
teach
high quality staff.
Yeah.
And the patient experience declines.
And if they're working for some organization, it becomes the organization's job to train these folks in your office, not yours. They don't really give you an opportunity, or you don't have time, like you're saying. And so everyone just kind of divests from the whole, experience.
Yeah,
it's
it's kind of it's that stuff. But on the counterpoint is, I mean, this is why leadership training is important. Learning how to train your staff is important. Teaching customer service, physician leadership within a practice is important to make sure the customer experience is exemplary. So the patient has a better outcome and is happier, really, with the whole experience, not just the 10-minute interaction they had with the doctor, because they're going to end up, hey, what's this bill mean? What do I do after my treatment? And it's innumerable. Like even when I needed something from one of the doctors, and I had to call their office and ask how to get a device. The person taking my call, after I repeated the same basic information about 5 times, they still couldn't get it. And I said, I'll just call you back.
Try again. Yeah.
So some of the staff in these practices is so marginal that it's a problem.
And I don't think it's the staff's fault to be. I think what we're saying is really that it's the system's fault. Just to be clear, I don't blame the staff because they weren't trained and they didn't have an environment that lifted them up and empowered them to do a better job. So I don't want to feel like we're trashing the staff here.
No,
I think,
but in order to survive, people have to be hired. They have to be hired at a competitive wage. They have to be in a positive environment where they're trained, inspired, motivated, with incentives and led in an organization that has a good culture. But it's increasingly more challenging to do that when the reimbursement is going down.
Counterpoint to this whole thing we've been kind of lobbying for is that I do think my impression of like the late 70s, early 80s is that perhaps there was an excess in terms of the way reimbursement was done, and it got a little out of hand. And so I just want to say there are limits, right? Like I think there is a balance, and they should be careful with how they reimburse people, and it should make sense. I don't know if you agree with that or not.
Well,
you think there's...
I'm sure the politicians will be listening to us and will act in a benevolent manner toward physician practices. I'm sure they'll do that.
Sure they will. But I just want to say there is such a thing, because I know there's going to be people listening, especially if there was a younger me, I'd be listening to this and be like, yeah, okay, whatever. You guys, like, I don't understand business. You're talking about all this business and reimbursement. And I just don't want to think about that. I think this seems pretty superficial or, I don't know, just selfish maybe. You know, you could perceive that, right? Because we're talking so much about money, which is a taboo topic.
It is taboo.
So many ways.
And because it's taboo, it's not talked about. But my concern is that the medical students and the doctors coming out, they're like, what is the analogy? Lemmings?
Sure. No, I think
running off a cliff.
I think
and they don't even know.
Yeah, no, I agree, but I do think there's always like logic, and so I think we should apply logic to this stuff. So I'm not saying, you know, I also don't think it'd be right if it went up by 20 times the reimbursement, because then that doesn't make sense, because then we're cutting something else that would be more important. You just have to be considerate of the big picture, and I just don't think the way it's being done now is logical.
I don't know how this all settles out. I don't really know. All I know is the trend line for what is it? The past 30 years?
Yeah.
It's decreasing.
Yeah.
So you've got decreasing reimbursement. We'll just draw it out for you, and we could put it on the chart. And then you have inflation, which is a constant, which goes up.
Yeah.
It's just the two never seem to balance. And I don't know how it survives. I really don't.
I think it could. This is off the dome here. There will be a crisis, perhaps, where doctors don't play along, and either that will lead to a complete re-regulation so that doctors are re-empowered, or the opposite, where it is more controlled, like NHS, the British health system, Canada system. And then there's going to be a portion that breaks off from that and just does pure cash.
That's like the family doctor that I go to who says, I'm going to go concierge. I think a lot of family doctors are doing that as a way to escape the shackles of what they're being paid by the insurance.
Yeah. Or I'm concerned for myself that in however many years, 40, 50 years, that Medicare will be a very low yield insurance plan, because very few places will take it, because people will break off and stop accepting Medicare. And I have a chart. I can pull it up here. My turn to show a chart. All right. And I think you already said this actually, but it just shows, you know, the Medicare fee for service and then the private payers. And this is relative to the total cost of service from 2000 to 2018. And again, it just shows that Medicare is really not covering the cost of the services for these institutions. And it's sort of being made up by private payers.
What's the gray line?
The gray line is like cost, 100% of your cost of running your business is covered.
Okay.
So it costs this many dollars. Let's say it costs $1 to do the service. Medicare is going to pay me $80, 90, or sorry, $0.9. And so they're underfunding you for this level of service that you're providing. Private payers are paying higher than your costs, which is how any business or any venture is run, right? You have to have revenue so that you can grow.
But this is for hospitals.
This is for hospitals.
So this is for hospitals, total payments for hospital services as a percentage of hospitals' costs to deliver those services have increased for private payers. So even hospitals who get quite often a higher reimbursement
Are not cutting it. It's still not enough for hospitals. So that's a little scary to me because, again, if I have Medicare and these hospitals decide that they don't want to participate, or a private practice, whoever, then my insurance is useless. And I've been paying into a system that won't benefit me at all. And that's okay because it paid for my grandpa and my parents, and that's okay. But maybe I could be taking that money and investing it in myself. What if I had my own plan that I could put my money into? You know, these are just thoughts I've had, you know, that this is a frustration. And they point out, this is from the Congressional Budget Office, CBO, if you want to look it up. You would think that hospitals are compensating. So let's say if they have a higher percentage of Medicare patients, they try to get more private payers to offset the cost. It actually isn't happening yet. They haven't noticed that, where they're trying to offset their costs or shunt their costs over the private payers. That isn't happening yet. But I could see that happening in the future, where if they get more and more Medicare, they have to take more private or start decreasing their Medicare so they can compensate for their losses. And then it just gets really messy. So it's a little concerning. Now, someone might be looking at all this and wondering, why do private payers pay more? And this is also from the CBO, and we talked about it a little bit earlier, but I think it's just going over it. So there's trade secrets, so whatever that means. There's knowledge held by insurers and providers. They negotiate a price, they create a network contract, and that becomes the insurer's price for these different procedures. That's how private pay works. And then we touched on this a little bit. How does Medicare work? It's complicated. There's this group called the RUC, which is composed of 22 physicians. Ophthalmology has a representative, and then I think there's 10 other non-physician representatives. They make a recommendation on how many RVUs, or relative value units, each procedure or service has. So let's say this one has 2 RVUs and another service is 1 because the other one was twice as difficult to perform or it's higher risk. And then they take that and they multiply it by a set value, which I think is $33. And that's how they give you your reimbursement. So going back to my chart here, so they take that, and then they also adjust for local geographic factors. So if it's more expensive to deliver care, say in New York City compared to the middle of Oklahoma, they do account for that in some way. It's also very complicated, but it is structured. So it is somewhat transparent, which is an advantage, I guess, to Medicare payment versus trade secrets and sort of behind the doors thing. But as a result of this structured system and sequestration and reduction in overall planned payment towards physicians, we're seeing all the problems we've been talking about so far. Hope that made sense. So we've kind of, I don't know where you want to go from here. I think we've kind of stated our aims here. It's concerning. I don't think it would have changed my mind even now if I could teleport back. Although maybe I would have thought more about law school, maybe, and try to be like a white shoe firm. These are these like Ivy League firms. Try to get into one of those and go down that life. That's probably what I would have done differently. What about you?
No, I like what I do, and I do believe that I'm very fortunate in this particular specialty to have an elective component, which is, I tell the staff, I love freedom. I'm a proponent of capitalism. But I always tell my kids, for every privilege, there's a responsibility. So though I have a lot of drive and I have an entrepreneurial spirit, and I'm lucky enough to be in a field where there's an elective component, it does take a lot of work.
Yeah.
So I don't just work, whatever it is, 9 to 5. I work a lot. I work probably every day, but it's because I care a lot about what we do. I care about our patients, because if they do well, that is our reputation, and I think your reputation is invaluable. I've heard it said, at the end of your life, you have your name and your reputation. So I work hard to preserve that. There are times in my life where people have tried to impugn our reputation, and I stood up and I defended it because it's important to me and to us and to everybody who works with us. So I don't have any regrets, but it just takes a lot of work. It's not like I can have that easy work-life balance
Sure.
and travel everywhere and live a life, the stereotypical I'm on the golf course by 3 p.m.
Sure.
Doctor life.
Yeah.
I probably work, I don't know, 70, 80 hours a week,
Sure.
but it's fine because at the end of the day, I know everything is being taken care of, and we're always staying ahead of the problems.
Yeah, I'd say your three hobbies are Austin I, and Austin I. Would you agree with that?
That's a good one, Max. Good one.
Thank you.
All right. So why don't do you want to pivot and go to like, who do doctors work for?
Yeah. I think we can talk about that. Yeah, let's do that.
Or is there anything else you want to kind of polish off on this topic?
I think we've done a good job, I hope, of making our opinions clear and hopefully, yeah.
Oh, let me add one last thing. So if in the year 2007, we were being paid, or an ophthalmologist doing cataract surgery was compensated $720 for that procedure. In order to keep up with the average annual inflation rate, the 2024 reimbursement for cataract surgery should be $1,286.43. If a staff member that was working with me was paid $20 in 2000, then to keep up with inflation, just to keep up with inflation, that same staff member should be paid $35.73. But the 2024 reimbursement for cataract surgery from Medicare is $528.49. So the ophthalmologists are being paid 41% in 2024 of what they were paid for the same service in 2000, adjusted for inflation. Meanwhile, in order to keep up with inflation, the ophthalmologist who employs the staff member would have had to increase the staff member's compensation by, rough math, 75%. So that's where decrease in reimbursement affects all of healthcare. It affects the whole practice, because in reality, doctors' practices are small business. But small business is being acquired increasingly by big business, which brings us to, who do doctors work for? So I think we've talked about this privately, but do you know who the number one employer of healthcare, of physicians is in the country?
Well, I think it's still physicians, right? But
It's,
overall,
well, the number one health, well, no, actually, no.
you're saying
So
organized.
Less than 50% of physicians are self-employed now.
Okay.
It's,
But that would still be the majority, or the still a greater percentage, right? So let's say,
no, let me show you this statistic.
right. So I guess I think we're saying the same thing. I'm saying that there's a decentralized percentage of doctors that still work for themselves or for other doctors, but then there's a centralized. Does that make sense? So like the percentage that work for Optum is not greater than the percentage that are not working for Optum.
Right. Optum is, however, the number one employer
Yes.
of physicians in the country.
Like a single entity that employs physicians. But I'm still saying, what I'm trying to say is it's not like the majority of physicians are employed by Optum.
Right.
Does that make sense?
Yes.
So
So who is Optum?
it's the United Health Group, I think, owns Optum.
Read
United
on.
Health Group is what it's called. So that I think is the overarching entity that controls these different things, the insurance company, the Optum services, which we can talk about.
Yes. Okay. Yeah. So United Healthcare owns Optum, and Optum controls pharmacies,
Mm-hmm.
hospitals,
Mm-hmm.
physicians,
Mm-hmm.
physician practices, and they employ. So I pulled this article from, the date on this is April 2023. United Healthcare Group's Optum continues to scoop up physician groups and cement its place as the largest employer of U.S. physicians. Optum now employs more than 70,000 physicians. And then just last week, another update came up, and it says Optum now has nearly 90,000 employed
Really?
and affiliated physicians. Optum, the
Wow.
largest employer of physicians and parent company of ASC chain United Surgical Partners, clocked 70,000 employed physicians at the end of 2022. The company also cited more than 40,000 advanced practice clinicians, like, I guess that would be like physician assistants, nurse practitioners, and more than 100 health plan partners.
Right. So
Massive.
it's interesting. So basically, an insurance company has started a separate company or a portion of its own company that runs hospitals. And this within this thing called Optum, they contract with other insurance companies to provide care to patients. So it's kind of like a Russian nesting doll of insurances and all that, which has a lot of implications.
Yeah, it's an incestuous relationship in some way, because the hospital that you go to is owned by the insurance company that is paying everything. And the hospital, which owns the insurance company, is owned by the insurance company, also owns the doctors,
Mm-hmm.
and they also own the pharmacy
Mm-hmm.
and all the associated steps in that wheel.
Now they do. I went to Optum Health's Code of Ethics Q&A, which is for their employees. So here's a question that was on the Q&A. I think it's kind of interesting to kind of combat what we just said. So I work at Optum Health and received a request from a colleague on my old team at United Healthcare for some information related to reimbursement rates of other payers. May I provide the data since we are part of the same company? Right? This is the concern that Optum Health, which negotiates with other insurers, will get trade secrets and be able to affect United Healthcare's insurance rates. That's what kind of what we're getting at here, is that there's concern for conflict of interest there.
Right.
And the answer that they give in their code of ethics is not without consulting your business legal representative or compliance officer. Optum Health's provider businesses contract with competitors of United Healthcare and may receive competitively sensitive information, which must be protected, and sharing the data requested without review and approval could be a form of unfair competition. And so basically, they tell them not to do that. So that's good, at least. They do have a code of ethics, and it specifically addresses our concern here. Is that what it's like in real life? I don't know. I don't know.
Yeah. And there has been a centralization of insurance providers over my career. So when I came out into practice, I had to apply for 30 or so different insurance plans. Now, if you're coming out, you only need to apply to about a dozen.
Yeah.
And it really, 5 of them are the main ones. So off the top of my head, it's Aetna, United Healthcare, Blue Cross Blue Shield, Cigna, and then everything
Medicare.
and then everything starts dropping off after that.
Mm-hmm.
So in health insurance, they are, I mean, we've all seen the Dr. Glaucomflecken videos about health insurance. I mean, is health insurance there to, what is the primary, health insurance is a business.
Mm-hmm.
So the business does the best. If I'm the CEO of United Healthcare, I do the best if I can collect insurance premiums from the most people and
Most healthy people.
and they never consume healthcare.
Sure.
And then even if they, in the ideal scenario is morbidly, they stay healthy and then they pass away suddenly. So they never really consume any healthcare, but their insurance premiums were collected while they were alive. And then the other game is that they require patients to pay an out-of-pocket deductible every year
On top of,
so they don't really have to pay anything until the out-of-pocket deductible is met. And then
Yeah.
you would think you met your deductible, but then it resets every year.
right.
And then you have to pay co-payments and co-insurance. And so it's like, it's in some ways you see that insurance is really playing a game with the very people it's charging premiums. In a way, it's denying things. And when we want to do something, we have to ask the permission and blessing of an insurance company representative to approve a procedure, and sometimes they deny it.
Sure.
So it's like insurance can be, you just need to realize what it is.
Do you know, I know the answer. Do you know who created the first insurance program in the United States of America?
No.
Baylor. It's in Houston. In the 1920s, they created an insurance program where teachers at the public schools would pay $8, I think, a year. And that would guarantee them services at their hospital because they were struggling financially. And so they needed a way to have steady income to keep the lights on. And it just grew from there. And we can dig into it, but it's actually, there's a lot of pieces to the private insurance puzzle. So there's the patient, then there's the employer, because we've tied private insurance to being employed. The patient doesn't, yes, they pay these monthly amounts to the insurance company, but actually your employer is really who's directly interfacing with the insurance company and picking overall, like, what plans are we going to have, how much we're going to pay, what's our portion. And so there's actually a disconnect between the patient and the insurance provider already. And this actually leads to increased costs because the insurance company will charge the employer more to insure the patient. And the patient doesn't quite feel it directly, but they actually do get charged that amount by reduced benefits or income, but it's indirect, so they don't notice it as much. So these private insurers get more money, and then they pay the doctor. And then again, the patient is actually who goes and talks to the doctor. So it's a web here. And so, but you can see how this web disconnects the payer from the patient, and it creates a weird relationship between the doctor and the patient. And
so, when I was in medical school or residency, people would talk about third-party payers. And I thought, I don't know, in one ear, out the other.
sure, yeah.
But if you think about it, when you go to the grocery store and you go buy eggs or a bag of chips, the payer is the customer, and then the seller is the second party. So I'm the first party, I'm the customer. The seller, which is the grocery store entity, is the second party. And so the most efficient transaction is when the buyer and seller work directly. But when you have a third party, such as an insurance company, and it's like if you go to the grocery store and you want to buy those same bag of chips and you check out as the customer, but you don't pay anything, and you say bill it to my insurance company, then the buyer and the seller have both become somewhat disconnected from the reality of the transaction.
Mm-hmm.
And so you're saying when employers work with insurance company to help provide insurance for the employees of the company, then there's like a fourth party.
Mm-hmm.
There's the employer
Mm-hmm.
and the insurance. So the more disconnected you are from reality, I think in the long run, it's not a good thing. Like every time you went to go buy gas at the gas station, get a haircut, and you had insurance cover it, you don't know what anything costs.
Mm-hmm. It's a challenge because health insurance is something almost everyone will need to utilize as an insurance, whereas most insurance you do not utilize, right?
Yeah.
You were talking about something very transactional and frequent, going to the grocery store. I think that's a great analogy. But most insurance is like going to Disney World. You know, you only go there like once every 6 years, 7 years. And so the frequency of which these transactions happens amplifies that the issues with the disconnect in my mind.
So I
Does that
think,
make sense?
yeah, to bring it back, if you're in medical school, think about what you're doing and try to understand the business of every touch point that you have during your training or even before you go to that. Well, no, I guess the only time you can do it is when you're in your training. Think about, the dermatologist, how do they charge for their services? The OB-GYN, how do they charge for their services? The radiologist, how do they charge for their services? And just be curious about those concepts, because the more informed you are, the better choices you'll make at each step along that career journey that you make. It'd be like if you're going to law school and you had no idea how attorneys are paid, you just wanted to serve and represent people and serve their best legal interest, but you had no idea how they got paid. I don't think you're doing yourself a service along the way. Or if you're going to engineering school, or even if you don't even go to school and you say, I want to be a plumber, or I want to be an electrician.
Well, you go to a technical school.
Yeah, or technical school, and you had no idea how you're paid. You just, I love plumbing. But if you're entering a field where the payment slope is one way, it's buyer beware, as they say.
And you know, the big challenge is that healthcare is, again, so vital, so frequently accessed, and it is, at the end of the day, you said your reputation and your name. Your health is really the most important thing you have. It's, you know, arguably more important than money. You can be very wealthy, but in poor health, and what's that doing for you? Nothing.
Yeah.
And so it's tough because there's such a moral, ethical, personal part of healthcare that makes the whole financial side of it really sticky. We maybe don't have to go too far into that, but this stuff is complicated.
And then you want to share what you know about private equity?
What I know about, I mentioned a little bit before, they're companies that they look at an investment, which in this case would be a healthcare institution, a clinic, could be a dental practice, whatever. And they go, what is the real value of this clinic? And how can we realize that true value with investments and making adjustments to billing, all this? I think I had a statistic somewhere in here, or maybe I just read it, but once a private equity place hires or purchases an ER, their billing goes way up. The amount that they're billing out, their reimbursements, everything flies up. Does the quality of care go up? I don't know, but that's kind of the goal for them. Build up the practice, get the value, and then sell it to an even bigger fish, I guess, a bigger firm.
Right.
And it just keeps going. It's almost like is that a pyramid scheme? I don't know. It's a little funny, but there has to be a limit, right? At some point, you'll exhaust the value of whatever this thing is. And really, it seems like private equity, from a physician standpoint, is great if you're about 70 years old or something, you own your practice, and you're getting tired and you'd like to retire and cash out. And for whatever reason, you're not interested in kind of lifting up your younger partners and want to be partners. And so you sell and you get out. So it's really great if you're a certain age in a certain situation. But for most of the doctors in the practice, I imagine it's not good for them from a financial standpoint and from a quality of life standpoint. You're talking about burnout and all that, because now you're a money machine. You're not a doctor. You're just a profit vehicle.
There's I think private equity and physician-owned practices that are not owned by physicians, there's a pro. Or as one of my friends told me once, Shannon, there's a price to pay for everything. So if you want that work-life balance and you want to not deal with the headaches and hassles and stress of running your own business, then you can relinquish control. You can relinquish autonomy to the larger entity, the private equity group, the hospital corporation, even like Aetna. No, I think it's the other way around. CVS owns Aetna Insurance. And so Aetna and CVS pharmacies, they employ physicians. They're a large employer of physicians.
Like Doc in the Box. Kind of
Right.
thing. Okay.
So you lose autonomy and freedom, but you gain work-life balance.
Which is a different freedom.
Right. Which a lot of people value over autonomy. But I don't know where it'll end, because ultimately I'm not convinced that large business entities care as much about the endpoint consumer, which is the patient, as the doctor who is boots on the ground taking care of the patient. And I don't know how it's all going to sort out, but when doctors they're almost treated like, and I love the military, but soldiers, and they have less control. Yeah, I'm not so sure that's a great recipe for success, because ultimately when I'm facing the patient, I want to help the patient, and I want to be able to make the decisions that are in the best interest of the patient. But when I have a larger executive organization structure controlling me like a marionette, I don't have that control, and it's problematic.
Yeah, I've never heard someone go, boy, I really love going to this PE firm's own physician facilities. Like, does that make sense? Like, the brand isn't, or the patients don't connect with that, and they don't build that relationship.
Yeah,
where it's like, I know Austin, I know whatever. Like, they know the doctors, they know the people, the family, whatever.
Even in the businesses that I've interacted with, like, let's say our medical record software company, it used to be privately owned, and we had much better customer service back when it was privately owned. When it got bought by a larger entity, a private equity group, then the level of care and customer service went down. And I really can't think of let's say our accounting firm that we had when it was privately owned. I think we got a better level of service. When it got acquired by a bigger entity, I think the level of service is not as good.
So this might be I'm putting you on the spot a little bit. Earlier you mentioned, you're a fan of capitalism. Isn't this all just an expression of capitalism and money?
It is.
And efficiency and growth,
It is.
Pushing
And I
back
understand
on that
it
a little bit. So
totally valid point. But I think thinking as a advocate for physicians, physicians should understand these externalities that impact their livelihood, that their working away and investing the prime of their life, their 20 to 30 year age range of life to get into this game.
Yeah.
Just be aware.
Yeah.
There's different perspectives, and that's a perfect point.
So I guess then your expectation in some ways is that, well, assuming this is not good, patients don't like it, doctors don't like it, that the capitalism will steer us away from this, right? Long term.
I don't know.
Or will there be no choice because it's the system's so set up in a certain way that you can't bounce in a different direction?
I don't know. I just know that whatever path we're on is somewhat unsustainable.
Mm-hmm.
And it is, I can only control what I can control. So from a selfish standpoint, I'm thinking, oh, I want to maintain my autonomy and have freedom and be the point of delivering the best, most compassionate care to our patients who are our customers, and have the freedom to make the best choices for them. And I'd rather not have a larger entity controlling me. That's just my personal bias.
Yeah. Counterpoint would be maybe freedom is, we already talked about it. Yeah. Quality of life, not having to worry about the administrative stuff. And maybe they feel they can best provide for patients if they have deeper pockets and better access to super specialized care.
Which leads to the counterpoint to that is the doctor, let's say the doctors are the owners of the practice. It is really their responsibility to recruit, hire, retain, train outstanding executive staff of their own to help run and manage the business at all levels. So really, that's what we're having to do on a daily basis. It's a talent. It's a war for talent. We need to hire and train our staff to provide support for the doctors and the rest of the staff, so we remain free and autonomous and self-sustaining, and a practice, an organization that the people who work with us want to stay at, and we are able to attract high caliber talent, people who want to work with us.
And you said this earlier. I mean, it does take a special person to do that, though. Not every doctor may be equipped to be the hero, right?
I wasn't equipped.
Yeah.
It's just something you learn.
Sure.
If you're working with us in another decade, you'll know a lot more. If you are working with us in 2 decades, you'll know
a lot
as much as me, if not more than me.
Yeah.
So that's really the cycle of a business is develop. I mean, you're the new guy, but our job is to have recruited you and develop you and incentivize you so you grow, and you're in many ways part of the succession plan of a successful business.
Right.
And all businesses have to do that. Otherwise, they will either be acquired or they'll perish. Most of medicine, I think people need healthcare. They need that in-person interaction. I do believe it could be virtualized to some extent in the future if technology catches up. I do believe that there will be non-human work being done in medical practices over the next 10 to 20 years. Everything will evolve, but ultimately the principles of hiring high quality people, because ultimately people want to be treated well and feel like they're always going to have problems.
Sure.
And doctors are tech support for human problems. And when you call tech support, you want competent people who care, who are knowledgeable, and treat you well, and then you'll come back. So that's kind of our business model.
People want it all, though. They want high quality. They want low cost. It's hard, but in healthcare, you realize not everyone is a millennial, super tech savvy, kind of person who can interface with these technologies and know what's going on. Usually they're a little older. Maybe they have some health problems. Maybe they grew up in a different era and they need a person that can just really be a person with them. And I think even those millennials need people too, because we're still just humans. We're the same.
Everybody needs people. I don't think so. Even when COVID hit and there was this trend toward telehealth,
Yeah.
I did not instinctively feel like that was going to be sustainable because at least to do what we do, we need that in-person interaction, and there's no way to virtualize that.
Even with, if you know anything about ophthalmology, we have so much technology in our clinics. We have scans for this, pictures of that, all this stuff. Even if I can put that into a box and send it to a patient's house, it's never the same as looking at their eye with a slit lamp, which is the little microscope that we use. I mean, that really tells me everything.
And then even just being in front of the person,
looking at them
and getting the vibe.
Yeah.
Because so. I learned, there was this interview I saw the other day where a person said, your gut never lies to you. So if somebody seems like they're a creep to you, they're a creep. If you think somebody's lying to you, they're probably lying to you. And so that you can't pick up these things, in my opinion, through a virtual experience, but you can pick it up when you're right there. There's some palpable human sense that we have where when I'm talking with a person, I can gauge how worried they are, how concerned, what really bothers them. I can read between the lines. It's very hard to do that over the phone.
I mean, I think test questions for medical school try to give you all this subjective data and all this. They're like, Mr. Jones has right upper quadrant pain. Their lab is this, but they never give you that subjective thing. And that's really what you learn as a doctor. And you get that by being with patients, face to face, looking at them. I could look at a set of vitals and think the patient's fine. And then you actually are with the patient and you see their hands, you see the way they walk, the way they talk, their clothing, is it disheveled? All these little things. And I go, this person's not well.
Nonverbal.
The numbers look good. But that's on paper. It's the real life that really tilts it. And so that's the art of medicine, but it's also like the reality, I think, is that our brains, our eyes, our whole thing is meant to be like this. And I don't know if we can match that. Now, can a computer start to, I don't know.
We'll see.
I don't know.
Time will tell, but we'll have to evolve with that.
Yeah.
It's a
little scary.
Yeah. The society will evolve with that.
I don't know how we got to AI.
I don't know, but
it's great.
It's good.
It's good to be here.
All right.
So we talked about who people, actually, let me just real quick say the top 5 employers for physicians, just to get it out there. We said Optum, that's the biggest. That's United Healthcare spinoff. Ascension, which I think there's some here in Austin.
Ascension is like in Austin, it's the Seton community, Seton Hospital, Seton Clinics.
They have 49,000 physicians in their network. Hospital Corporation of America, which I worked at as an intern, they have 47,000 employees. The VA is 26,000 employees, and Kaiser Permanente is 24,000. So just anyone curious, just to wrap up who do your doctors work for? Those are the big organized ones.
Right.
And then there's a whole sprinkling of the rest. I have a chart here. I think this is also from the CBO. Yeah, from the Congressional Budget Office. Just to wrap this up. So on the y-axis is the percentage of doctors in certain types of practices, and then the x-axis is time from 2010 to 2016. And we can see independent solo practices diving down. Now, we don't have error bars here, but 41% down to 35% in a short period, 6 years. And then hospital healthcare system boosting up. And then we can see the medical group going down. It doesn't show here like these private employers, unless that's what they are implying by hospital
healthcare. That
healthcare.
ends in 2016. I think the trend went downward, and now that if you add 35.3 and 21.2, you get 54.5% are independent or medical group. I believe that has now fallen below 50% over the subsequent 7 years that followed 2016.
Yeah. So just to wrap that up, things are changing. They'll keep changing. Will it go in the same direction? We don't know. Okay. So another thing I wanted to talk about, or a couple other things. We can talk about, you want to talk about pharmaceuticals, or?
Go for it.
Okay. So we've been talking only about insurance. There's another big player, right, in healthcare. That's pharma, big pharma. I can't really think of any instrument, medication, anything that I use that a company isn't selling to us. I don't think any NIH lab is selling to us, right? They don't do that. They create a product, it gets patented, it's sold or owned by whoever comes up with it, and they create a company, and then it's either they're bought or they sell the product. So ultimately, you have to interface with pharma or private industry to get the job done, because medicine is all about tools and medicines.
And are we talking about pharmaceutical, or are we talking about industry in general, like devices?
Industry, I guess, would be a better term.
Got it.
So industry, but I might call it pharma just to bring it all together. So this is a big deal because there's a cost associated with that, and doctors historically have received money from pharmaceutical companies and industry for various purposes. In the heyday, in the 80s and 90s, they would fly you out to Vail and wine and dine you and all this. And why were they doing that? Well, they're trying to influence prescriber patterns. And I think, fortunately, this has been reined in by the U.S. government, honestly, to make it more ethical, more transparent. In fact, there's this thing called the Sunshine Act. You can Google this yourself and look up any provider you see or want to see. You can see how much money they receive from pharma, from industry. So the next thing I want to talk about is industry. So when you're in medical school, at least when I was in medical school, industry, pharmaceutical companies, device companies was taboo. We were actually explicitly not allowed to interface with them in any way due to concerns of conflict of interest, which is important thing to keep in mind when you're taking care of patients. You want to do right by them and provide them the services and treatment that makes the most sense for them medically, not because of any external factor. But I think that view it's good, but it's a little narrow-minded, in my opinion, because the reality is every product that you utilize is sold by a company or industry. So you have to know what they're about and what their goals are, what they're doing, why they're doing it, their history, how they try to interface with you and make more money. I mean, that's what their goal is, and to take care of patients. I do think they genuinely do care about patients and want to be innovators, because they are. Now, they're not alone, and industry definitely benefits from NIH dollars, public money. And in fact, for every $1 spent on NIH research, there's $2-point-something worth of revenue for private companies generated from the discoveries made from public research. So, there's a connection there that's really important. And we have to realize the stream of thought and how it goes from concept to realization to marketing to in your clinic to helping the patient. So what was your experience in medical school with pharma?
I was oblivious to industry in medical school. I have no specific recollection of anything having to do with industry. I was all consumed with learning the material. I became aware of industry in residency.
How? What was that interaction?
The recollection was some of the books would be provided by a company called Allergan.
Mm-hmm.
I got my Will's Eye manual from an Allergan representative, and I would get Post-it notes and pens that had certain products on them, and I would meet with lens implant representatives, and that was not uncommon during residency.
No, I think that's still the case now. Branded items and stuff like that, that's been kind of pulled back on through regulations through the U.S. government. Really, they don't give out pins and little
Right.
trinkets and stuff like that. They have had to rein it in quite a bit, which is good. I think the stories I hear and read, there's an article let's see, this was in the Washington Post by Dr. Ahari. Dr. Ahari worked at Eli Lilly in the 90s. He is now an EM physician, I think in Pennsylvania or somewhere like that. And he really goes over what it was like back then in terms of the ethics and the goals and the way that pharma thought about physicians and patients and what was ethical and what was not. And it was very cutthroat. It was very on the edge. And it was eye-opening to me to see what he talked about. And I think he mentions that whole NIH to publicity or to private revenue. He also mentions that for every $1 spent on research within the industry, by industry, for the actual development of a product, they spend $2 on marketing and promotion. So a 2-to-1 ratio on the actual marketing and not on the research. So they talk a lot about their costs when the pharmaceutical companies talk about their business and how expensive it is, but really most of their cost is moving the product out. And so I think that was an extreme back then. So I'm happy with how things are now. And there's even this thing called the Sunshine Act, which demonstrates or publicly shows how much industry sort of interfaces with doctors on a monetary basis, whether it's providing food for staff, meeting with doctors and having dinner, those sort of things. That's what's currently allowed. I'm looking right now at the open payment data from cms.gov, and it said in the year, this is 2020, 640,351 physicians received some sort of payment from pharma, and totaling about $2.17 billion in money. And
This is in the United States?
in the United States,
There's 640,000 doctors in the United States?
that receive payments. There's 1.077 million, I think,
Wow.
doctors.
Uh-huh.
So a majority of doctors interface in some way with pharma that they get on this website with openpaymentdata.cms.gov. I've highly recommend this website. I think it's interesting and valuable, and it is good to have transparency in these interactions. But the thing is, there's extremes. I think the reality is there's certain people that interact more with pharma than others, and you kind of have to make a decision what kind of role you're going to have with industry. The extreme of that would be a key opinion leader. This is someone who is considered, at least by the pharmaceutical industry, to be someone of prominence and some level of expertise in a field. And they even and their role is to discuss the product in a setting and demonstrate its usefulness. This idea was created by Pfizer in the 50s. They learned that they were wondering why the money they were spending on advertising didn't yield the amount of sales that you'd expect. I should spend more on advertising, therefore sell more XYZ product. And they looked into politics, actually, and they learned that there's a similar problem in politics where they would spend a certain number of dollars on ads, but they weren't getting the same number of votes that you expect proportionately. Really, people seem to make decisions based on the opinions of a small number of people, leaders within their community. Maybe it's a preacher or a priest, or their local government person, a councilman or councilwoman, whoever. So they went, that's interesting. Maybe we should have people like that, people that will say and build up their reputation and make their voice louder so that people can hear that, and maybe that will influence the way they prescribe medicines or use devices. So that's the history behind all this. And key opinion leaders are valuable. I think they're really good to have. The concern that some people have, and there's a graph that I sent you, is that it becomes less about innovation and more about marketing. On the flip side, you have people in academia that are highly innovative, at least in general. Maybe they're pushing for more discovery, they do more research compared to a key opinion leader, but they don't know how to distribute this innovation, which is useless. If I come up with the cure of cancer, but I never tell anyone, it's useless. You have to be able to get that to the world and communicate its effectiveness. It's important. So you don't want to have, and this chart shows innovation on the y-axis, very high at the top, and then on the bottom is distribution, from low distribution to high. And they're saying an ivory tower, which is sort of like, let's say like a Harvard or something. They have a very innovative product, but they don't know how to distribute it. And then down on the bottom right here, they have a high distribution with low innovation from, say, the key opinion leaders in blue. The what they like to call innovation and knowledge leaders are in green. And ideally, you want a think tank, a merger between industry and academia that optimizes our ability to innovate, but also apply our innovation in real life practice. So that's a long, rambling way of saying that pharma is really important. I think interfacing with them is good, and I think we should play a part in this and try to be steering these decisions, but also being mindful of the influence that pharma can have on you.
Do you think the influence of industry is a net good?
Yes.
I would say so as well. I would say an interesting personal anecdote. When I was at your point in my career, I don't know why it was, but I felt almost like I wanted to engender the approval or somehow I wanted to impress the industry reps.
Mm-hmm.
And so I would listen to them more, and perhaps they had more influence. As I've become more seasoned, I am more agnostic to industry. I go only to the best products. I don't have any affinity to any company, for better or worse. So, but I think that's a more pure way of practicing medicine. So I guess my advice to the younger physician is avoid, a lot of industry reps can be very convincing, very engaging, somewhat seductive in their ways of convincing doctors to utilize their products. Always be aware of that. The industry reps are their mission is really to sell their product.
Mm-hmm.
And if you really don't need their product, sometimes they make it very difficult for you to say no. But if you really don't need it, just politely say no. It sounds easy, but it's actually kind of awkward because they can be kind of pushy,
Mm-hmm.
in a very professional way. So it's very interesting
No is like a trigger word
to
for
them.
Yes.
Yeah.
It means try harder,
Yes.
which is a little off-putting when you're not used to it, at least for me.
Yeah. Like even recently when we were trying to make a decision to purchase an expensive piece of equipment, we were contacting different tier one industry companies to compare products. And when I started leaning toward product B rather than product A, the representative from product A feigned indignation, saying, I can't believe you would do something like this. And I just saw through it as exactly what it was, feigned indignation but it's like a sales technique. They're very well coached to how to present things, and they're very good at delivering this process of education but sales at the same time. It's interesting.
And they're
It's a
just
whole
one
other-
part of it. Again, there's the KOLs, the key opinion leaders. Those are the doctors that are participating with these companies. So there's a lot of influence, and you have to kind of get good at reading between the lines.
Yes, it's that gut reaction. So even with KOLs, some of them I highly respect. Some KOLs, I can see that they're actually financially motivated, and they over time have demonstrated a track record that they will say a lot for various companies, but their track record shows that they're kind of strongly biased based on where the money came from. Because they'll be an advocate for one product in the 1990s, and they'll be an advocate for a competing product in the 2000s, and then they'll come back. It's just, you can see that that's their diversification strategy for their income. They get it from being a key opinion leader, a paid spokesperson. So be aware of that if you're the audience, the young impressionable doctor. Just always follow your gut.
Yeah, you're not always going to have a sunshine act to tell you people's motivations. So you have to use your own barometer and senses, like you said, your gut check on what they're about. So that you'll learn. You can't really, I don't think there's a class they could give in med school to teach you that.
No, but be aware.
Be aware.
Is there anything else you want to talk about on this subject?
I will say, though, a lot of studies have looked at whether or not these interactions really do make a difference in physician behavior. And it shows that there really isn't a strong tie, say, between a pharmaceutical sponsored event, like a dinner where they talk about a product that is innovative and new, you need to learn about it, and whether or not you'll actually prescribe that. The yield is pretty low. So that's reassuring that doctors are able to maintain their integrity. They did find, though, that the older style, what I kind of maybe said before, in the 80s and 90s, when it was really, really over the top, like flying people to Cancun and getting them resorts and all this, that did have an impact on the way people prescribed. And so I'm glad that they curtailed that and made it more ethical. And so I'm happy about, I'm actually at peace with how we are right now with pharma.
The Sunshine Act. And so that website, can you be sure to send me this information?
Yeah,
because I'll post these links up. That's very good information, because you can actually go online to that website, and let's say Dr. Jones is a key opinion leader. You can, in your community, you can go on that website and look up, how much are they being paid by industry?
Yeah.
I wonder.
And it'll tell you who paid them, how much, when. So it's extremely detailed.
So, for example, what is the website? I'm going to do myself.
Openpaymentsdata.gov. No, .cms.gov.
Openpaymentsdata.cms.gov.
So we can search for you.
I'm going to search me. Let's see here.
Shannon Wong. I'll do it with you.
Yeah, individual provider.
Ophthalmology. Yeah.
United States.
I found you.
Austin. Search the data. Shannon Wong. Okay, cool. Let's find out. 2022. $1,201.95.
Which is much lower than the average.
Let me see. Oh, general payments across all years. What's the blue line here?
Blue line is you.
Oh, shoot me. Yeah.
And then, so the average specialty mean for 2022 was $3,700, give or take.
Yeah.
And you were well below that.
Yeah.
So,
these are mainly dinners. They take you out to a restaurant, and it's a conversation which I think is actually very productive between the representatives of the company. I even list my stuff there. I don't care if it's public. I don't care.
I mean, it is public, yeah.
Yeah, it's fine. But these are the companies I'm meeting with. You can see Alcon and like J&J and Allergan, and that's when you go out to dinner. But if you search the key opinion leaders, which I don't strive to be one, their compensation is significantly different.
Mm-hmm.
And again, I would say a majority of key opinion leaders are great,
Mm-hmm.
and I listen to them. But there is a significant minority where I can see that they're highly biased.
You have to be careful with
Yes.
anything. And so, yeah, I feel good about where things are at, how open things are, and how regulated it is. This seems like a place that needed to be regulated. And I think that my med school's approach, just don't even think about it, don't even go there, was, again, short-sighted, because it's the reality. We didn't even talk about this, but after you leave med school, you're going to have to learn things that aren't in a book, that aren't taught to you by a person in a lecture hall. This is part of how you learn. Go to these events, because those are the products that are innovative and new, and your patients are going to want them and need them.
Yeah.
And so you need to know what they are. And then, of course, do your due diligence, talk to peers, read the study that led to its FDA approval. I try to do that for any new drug that I prescribe.
Or device.
Or device, yeah, or
Yeah,
device.
so in our world, we use a lot of consumable goods. Lens implants would be probably our biggest consumable item. And yeah, we work collaboratively with industry on a regular basis because we use a lot of their devices.
That's the real life. And that's
Yeah.
what you would do with any product in any business. Like if I run a repair company and someone came to sell me a new set of hammers, I would like investigate the hammer, learn more about it.
Yeah.
All these things. It's just due diligence. And if you never learn how to interface with them appropriately, you're putting yourself at a disadvantage and maybe making yourself more influenceable, if that's a word, more likely to be influenced in a way that you're not hoping to be influenced. And I think going back to the key opinion leader thing, again, I guess I kind of framed it in a negative way, and then you framed it a more positive way. And I think it is still positive because it does put doctors in the room with people that make decisions. And so they are the people that actually interface with patients. They actually know the problems facing your subspecialty or whatever you do. And they can give good real-time feedback on devices, on medications that is valuable. So I'm actually glad too that we have them for that reason too. Just having someone in the room where it happens, that's a doctor, and it's not just a bunch of pharma guys.
I would say the most impactful decisions we've made in our practice over the past decade have been because of conversations I've had with peers that I trust. Now, these are not necessarily key opinion leaders, but they're doctors who are in a very parallel practice style that we have, and I trust their opinion because of their experience.
That's the real opinion leader.
That's the
right?
real opinion
That's what you have
leader.
to find.
Yeah.
Who are the real deal in your whatever you're doing? Get to know them on a personal level, and generally people are nice and willing to let you pick their brains and stuff, right?
So like let's say if you had to get unbiased information and new ideas, if you had friends that you trained with, went to school with, and they're working, usually they're not in the same city as you, and you go visit their practice, it can be a game changer because they're going to tell you, hey, here's how it really works, and this is the real deal. Let me just tell you real quick, and they'll tell you, and it's brief. It may take 5 minutes, but they're telling you such impactful information, just friend to friend, that it can immensely impact how you practice. For example, I can think when we made the decision to build a surgery center or do laser cataract surgery or staff our practice a certain way or not do laser cataract surgery. These were all conversations I had with friends telling me, hey, this is what works for us. And I go, oh, really? Maybe I should do that too. It's very cool.
Yeah. Seek that out. It's hard. I don't think it's always built in crackerjack that you'll have that. So you network.
No, but cultivate those, because I didn't go to school with any of these friends.
Oh, really?
I met them along the way. I met them at little meetings here and there, sponsored by industry.
Sure. Yeah.
But you kind of like build a relationship, and it's usually, how you make a friend in school. Maybe you have a similar sense of humor, or you go, you can believe this guy, what he's saying? And you go, yeah, kind of laugh. And you kind of know,
Sure.
Hey, we kind of, we have a little similar thread that we can communicate with.
So takeaways from today, we learned a bit about physician reimbursement and the changing landscape of healthcare, in particular who employs your physician, and what the future of insurance is going to be, at least as best as we can tell. And we learned a bit about pharmaceutical and industry relationships with physicians. So these are big, heavy topics. I think we did a pretty good job, I hope. And I don't know, what do you want to talk about in the future? I think
stay tuned.
Stay tuned is where we're at.
Episode 4.
Yeah. 3 was a big one.
This is what they don't teach you in medical school or residency, but you need to know. This is really good information. Hope the audience finds it useful.
Ready to do our
and that's a wrap. Or should we? Okay, well,
we got to do our
okay,
thank
fine.
you.
Yeah. Okay, and thank you for seeing eye to eye.